or just jumping on camera?
Go right ahead, Steve.
Okay. Everyone, thanks for joining us today for Grad Rounds. I'd like to briefly say hello. I met some of you before, many of you I'm still excited to meet. I'm Steve Foose, so I'm the new director of Grad Rounds for the division. Very excited to take over from Brandon and continue the work that he's done to bring some great sessions to you guys. Really thankful too for the team that has worked and continues to work on Grand Rounds. Sarah, got Mark, the executive leadership team, and people I may be forgetting. So really just happy, excited to be here and to get started today. So for today's Grand Rounds, we have Dr. C.T. Lin. Background on Dr. Lin: for undergrad, he attended Harvard Medical School, Stanford, residency at UC Davis, and then had a fellowship at the National Library of Medicine. Dr. Lin is also the Chief Medical Information Officer at UC Health, and very importantly, is a ukulele EHR parody singer. Today, Dr. Lin is going to be giving us a talk titled, "I'm Sorry, Dave, I'm Afraid I Can't Do That." And with that, Dr. Lin, I'll turn it over to you.
Terrific. And can hopefully everyone can hear me all right. I'm hoping to do a couple things today. I have some slides to present, but I also am going to try to do a live ambient notes demo, which, cross my fingers, I can get a volunteer to do with me. So let me start with slides for a bit, and then I'll jump into the demo. And worst case, if the demo doesn't go well, we can do some slides that will replicate that. So here is my slide deck. Tell me if you can see that.
We can see that.
All right. I'm sorry, Dave. I'm afraid I can't do that. And no, I'm not referencing Dave Tanaka. This is the theoretical Dave from the movie 2001 and Space Odyssey. And I'm recognizing that this movie is now more than 50 years ago, and there may be some of my colleagues who've never seen it. And I would encourage you, if you're at all a science fiction fan, this movie is still a prescient movie that speaks to today's acceleration in artificial intelligence. And the phrase, "I'm sorry, Dave," comes from that movie and is actually quite relevant in our day and age. So I'm sorry, Dave. I'm afraid I can't do that. All right. We're going to cover a number of things. Ambient notes from Abridge is our current vendor in ambient notes. I'll cover that in more detail. In-basket art, which is automated response technology. In our early going for this, we may have called it PAM chat, patient advice message, chatbot draft reply. I'll talk briefly about summarization of the chart. The problem of AI transparency and my idea of maybe using an FDA nutrition label as the example. Automation complacency, which I think is going to be a growing problem, and possibly the Greek chorus. So I have now revised objectives, Steve, that we can maybe replace my talk with, but describing the benefits and pitfalls of generative AI, describing the benefits and pitfalls of generative AI drafting online messages, describing the challenge of explaining this to patients, whether a nutrition label could be helpful, and then the idea of automation complacency more broadly in our future clinical careers. This is my team. So of all the things I'll be talking about today, thanks to many of my team members who've done extremely great work in this area, including Dr. English, Dr. Seja, Dr. Simpson, and others in the general medicine department, as well as throughout the rest of the university. If you watch movies, this is from Prometheus, you'll know that the future of medicine is amazing, right? You climb into this thing and it's both your general internist and your general surgeon. You can have an appendix removed, you can have anything diagnosed and treated instantly. And so if movies are this great, then why, if the future of medicine is so awesome, this is all we get. This crappy thing sitting in the computer and this doctor complaining about it. Yeah, this is what we have. So from here, I'd like to jump into ambient notes, and I would love to have anyone who is willing to be my patient for a 3 to 4 minute interview. We're going to pretend that we are in person. Let me stop sharing. Do I have a volunteer willing for me to interview them and make up a couple of things? And please be kind and not be overly dramatic in my interview. Anybody?
CT, it's Amber. I can do it. Oh, okay. Go ahead, Steve.
All right, I'll do it.
Steve, great. I appreciate it. So this is a demo of what we've just started using at university in the last couple of weeks called a bridge. And Steve, thank you for volunteering. I'm going to just show a couple things on my screen. We have what's called a bridge inside, and this is in the demo environment. You can see that right now for the university clinicians, it's only available integrated fully into the EHR via iOS devices. And so if I bring up Haiku, I can actually find a patient on here. My test patient is called Cinco Testing, but we'll call you Steve today. That will be fine. And on the bottom of the patient's chart, there's a new logo called a bridge. And I'd load the ambient recorder. Best practice for us is to walk in with the recording started so that I can actually record the consent of the patient to be temporarily recorded. So I'll start the recording. And so it's now going. And as I walk in and wash my hands, good morning, Steve. Nice to see you again. I understand that we're going to be seeing you for a couple of things today. Before we get started, I would love your permission for me to record our conversation. It's a temporary recording that goes away in 30 days, but it will help me focus on you instead of having to jot notes on the computer. Would that be all right with you?
Yeah, that sounds good, Dr. Lin.
Great. And I understand you're here for a follow-up of high blood pressure, but that also you have some congestion you'd like to talk about. Is that right?
That's it.
Yeah, okay. Tell me what's been going on with your cough and congestion.
So I think I had a cold about 2-3 months ago, and I got the cough congestion back then, and it just hasn't seemed to go away since then. It's gotten a little bit better. It's still lingering and keeping me up at night when I'm trying to sleep.
So it's keeping you up at night when you're trying to sleep. Yeah, okay, good. What else can you tell me about it?
I've tried cough drops. They don't really seem to make a difference. Yeah, I've tried like throat gargling things with my throat to try to get that better. That doesn't seem to make a difference either. It's really not bad during the day. It just seems to be when I'm laying down at night.
Oh, mainly at night. I'm sorry to hear that. Okay, great. And then separately, in regards to your blood pressure, I've looked over your chart, and the last 2 or 3 visits, your pressures have been running in the 150s over 90s, and today, in fact, it's 155 over 95. And after this number of visits, and with your family history, I think it may be time to get started on a new medication. As I recall, you told me your father was taking this unusual pill, minoxidil, for his blood pressure. Does that sound right?
Yeah, I think that was for his blood pressure in his hair.
Yeah, I see. Okay. All right, let's move on to the examination. And as I examine you, I see that your nose has some boggy tissue, but no concerning findings. Looking at your neck, I don't find any bumps or lumps, so I find there's no cervical lymphadenopathy. Looking at the back of your throat, there's some cobblestoning findings, some inflammation in the back of your throat, but nothing that's too worrisome. Your tonsils are slightly enlarged, but I don't see any exudates on them. Listening to your lungs, they sound clear. There's no crackles, no consolidation. And your heart, I'm finding regular rate and rhythm and no murmurs and gallops. So I'm pretty reassured by all of that.
I don't know what that means, but that sounds good.
Yeah, right. I'll explain that in just a second. In my review of your chart, I'm seeing that your creatinine was 0.9 on January 7th when you most recently had a blood test. And overall, I'm thinking that this is a viral upper respiratory infection. It sounds like it's been going on for several weeks. I don't think there's need for antibiotic in this case. I'm not finding anything that's worrisome for bacterial infection. And I wonder if you've tried nasal irrigation with saline before.
I tried it once or twice, and it didn't really seem to help.
I see. Well, what I'd like to recommend is a neti pot or a NeilMed kit, which you can purchase over the counter. We have a pharmacy right next door. I'd like you to try that twice a day for the next several days and let me know how that's going. And on top of that, I'd like you to try some Flonase, 2 sprays in each nostril once per day for the next week. And then I'd like you to check back in with me. If you want to send me a message online, that would be fine. Any questions about that?
No, that all sounds good, Dr. Lin. Thank you. I hope it helps.
And then separately, in regards to your blood pressure, I think we do want to start you on losartan, 25 milligrams, one tablet once per day. I'd like you to do that for 30 days, and I'd like you to repeat a blood test for a basic metabolic panel the day before I see you next time in a month. And that way we can compare notes and see how you're doing. I'd like you to purchase an over-the-counter blood pressure machine if you haven't gotten one before. My preferred brand is Omron, and I'd like you to do that once a day, and then we can check in a month. How would that sound?
That sounds good.
All right, good. Let me stop my recording. All right, so on screen, recording completed. Please go over to your main screen. And so thank you for doing that, Steve. Everyone pause for Steve being a fantastic dummy patient for me. I didn't mean to say dummy, did I? Let me start with sharing my test environment. Larry IMOP and share. Tell me when you can see that.
We can see that now.
Great. And so under testing Synco, then what some clinicians will have to do is wrench into the schedule. And this is a one-time setup for note status. And I can show the status of the recording from ambient and insert that into my columns. Which of course, I didn't do that exactly right. I moved that over. No, one more time. Add column, there we go. And then if I have it here, move it a couple of times up. So you see how I have a status now of processing, and if I double click and open the chart, start my visit, and I now have defaulted in the ambient note type. And typically our test system is a little slower than the live system, but most people are reporting that in the time it takes to walk back to an office, about a minute or so, even for recordings that are about 30 minutes long, we can have a progress note written. So while I'm waiting for a minute, is anyone willing to volunteer their experience with it if you want to give us 30 seconds on what you're finding using this with patients, either at the university or, as I understand, Denver Health is using Nabla, something similar. It's already up, but I would sure love to pause here and ask for any feedback from colleagues who are using this.
Hi, this is Tish Bolshin. Can you guys hear me?
Yes, Tish.
Okay. Yeah, so I've only been using it for like 2 weeks. And I do find that I have some difficulty with physical exam, like annual well checks. Those have been a little awkward, and it doesn't get everything right. So, sometimes I just need to go back and do some editing. But I have not had to go back to the actual original transcript. I haven't felt that was necessary. So I feel like overall it does a really good job of filtering out like the flotsam and jetsam and just sticking to the subject at hand.
Thank you, Trish. Tish. Anyone else?
This is Annie Moore, and I'm sure I was accepted into the pilot because to see if someone as old as me could figure it out. And I've been really delighted with it. It, in my opinion, writes a much better note than I did. And particularly like little topics I might not have even put in the original note get captured. But I've been really delighted with it. So I was happy to be part of the pilot.
Great, Annie, thank you. I appreciate your feedback. All right, I'm going to artificially stop us here and refer back to the note. I haven't actually looked, but we have now upper respiratory, persistent cough and congestion, no signs of bacterial infection, try nasal saline, start Flonase, check back in a week, hypertension, blood pressure, start losartan, repeat basic metabolic, purchase over-the-counter blood pressure device, Omron recommended. So even the brand names sound pretty good here. And I wanted to see if it would catch something about the family history in minoxidil, and it did not do that in the plan. I wonder if it's referenced here in the HPI. Yes, the last sentence does reference father with minoxidil. So in terms of twists and turns, I actually had a patient go off for about 10 minutes during one of my visits about something that happened in 1979, and Abridge wrote that in one sentence by saying, patient refers to a trauma experienced in 1979, and was able to collapse that pretty effectively. So in terms of accuracy, we've been I've been quite pleased overall. And as Tish mentions, there's an occasional, maybe once in the last month, a hallucination of something that was not said during the visit, and then there are some difficulties with exactly what I verbalized or don't verbalize during a physical examination. There's some issues that you do have to read the note carefully. So from here, and what Tish was referencing is that you can actually go to linked evidence, and it'll actually give you the full progress note in SOAP format, and then also a transcript on the right. And if you highlight anything within the note, let's say mucosa boggy. Did I say that? And yes, it should refer to boggy tissue in the transcript on the right. So you're able to go through and talk about, did we talk about throat lozenges at some point? And it'll find that references to that in the transcript. From there, we also have something called the patient summary, where it rewrites the note in 8th grade language. And you can do this and copy it, use the copy all, and paste that into, for example, the wrap-up, and present that to the patient before they go out the door. If I were to paste this here, right, and if I go to previewing my after-visit summary, 8th grade language, you can show the summary of the visit to the patient sort of in real time. So there's some nice opportunities. We hope that over time this continues to improve. But overall, it's already been kind of a game changer for a number of us. Any other comments overall from colleagues? Amber has some comments. Eden has some comments. Thank you. Key things that happened today. Right. And then there was a mention that at university we have a tool that Dr. Altman built for us, problem-based charting, and for those who wish to maintain that, there is a little bit of copy-paste. It doesn't work natively with problem-based charting, and this is off on a tangent now, but Abridge is developing something called Danbient, diagnosis-aware notes, and combined with ambient. And over time, we believe that Epic's tools for problem-based charting will improve, and we're looking at a gradual migration over the next year or two in that direction. All right, getting back to a subject at hand. Thank you for allowing me that sidebar. Present this. All right, and Steve, let me know when you've got the slide back up that you can see.
We can see it.
All right, moving on. So the takeaways: reducing pajama time for progress notes. We're finding that some clinicians are reporting being done with notes an hour earlier per night in some cases. Patient summary is at the 8th grade level. Notes both more detailed in some cases and more concise, certainly more concise than what I was dictating before. The bad is you do have to remember to consent the patient for this recording. The recording goes away at 30 days. Verbalize your exam findings. So if you say, oh, does it hurt here? It has no idea what you're talking about. And then not yet to the level of pending orders of diagnoses or billing codes, but that's on the roadmap, it sounds like. The ugly is there's an occasional hallucination. It doesn't work with problem-based charting directly, so if you're interested in keeping that up, there will be some copying and pasting you'll have to do. UC Health currently has 250 licenses that we're doing a 9-month pilot, and we'll be reevaluating it going forward. I am aware that Denver Health is using Nabla, and Microsoft DAX is out there as a competitor, and so forth. I'm wondering if there's anyone on from Denver Health who can speak to the Nabla experience.
Hey, Jarrett Pytel here. Yes, I do clinical care at Denver Health, do integrated primary care and addiction. I hadn't seen the Abridge. I think the one downside of Nabla is that it's through you kind of have to go to a website, so it's not all in the Epic ecosystem. So you have to take an extra step to open up a browser. But generally seems pretty similar. I apologize, I missed the very beginning, but you can do some pretty nice customization with prompts, which is really great. I did have a quick question because I'm kind of curious if there's any discussion about how to get data that can be abstracted. For example, your patient history that you just did, that's only showing up in narrative, but it's not going to be necessarily searchable in like the family history side. So do you know, is there any movement towards making sure that these fields that are getting populated can, be identified and have a report run down the line?
Yeah, great. Jarrett, thanks for the feedback in regards to NABLA at Denver Health. I'm aware that the 2 or 3 ambient notes leaders are pretty neck and neck in terms of its development and use in clinical care. Suki is another one that's out there. Into your question, I think everyone is scrambling to develop codified data out of the narrative that we have now, right? As you saw today, everything's a big blob, and it's separated by diagnoses, but the diagnoses are also blobs. They don't actually reach into the problem list. They don't actually place ICD-10 codes, that sort of thing, but it's coming. There is a note reader technology through Epic, and also there's deep integration with all of these vendors where they're talking about how do we abstract, hey, I think you mentioned albuterol inhaler, let me pen that for you. I think you mentioned this ICD-10 code. Is this the one that you meant? These are the types of things that are under development. We hope the next 12 months we'll see something interesting in that space. So stay tuned. I think these things are changing. I'm going to keep going unless there are other burning questions. All right, and hey, Tom.
Hey, it's Tom McKenzie. I just wanted to give a little feedback about Denver Health. So, I've been using Nabla now for about 8 months. And honestly, I don't think I could go back. I am so in love with the product. I just feel like it has completely changed my approach to clinical care and find it's a total game changer. And I think you'll find a few other people at Denver Health who feel that way.
Interesting.
And then just to your last point that you made, one of the things that we do here at Denver Health is that as I write my note, I'm populating the visit diagnoses, or as I'm seeing the patient, I'm populating the visit diagnoses to tie orders to it. And then Nabla uses those to structure its assessment plan. So it pulls those in. So at least those elements are structured and could be pulled out later. And that's a really nice way to link what I'm doing on the computer to what Nabla is hearing in my visit.
Cool. Very cool. Yeah. It sounds like Nabla is right on the bleeding edge of allowing your integration between visit diagnoses that you're selecting and what it's hearing and writing about.
Exactly.
I think there is going to be much more sort of nuanced balance between clinician workflow of at what point do you start selecting what you're thinking and how does that merge with what the AI is thinking. And I think we're going to see a lot of iteration in the next year on tools like this. Thanks, Tom.
Yeah,
I appreciate it.
You bet.
All right. With your permission, I'm going to continue going. We will spend some time at the end. I would love to do some brainstorming about what your reactions are to where we're going. So just briefly, just so you can see it on the screen, the smartphone app on the left, the one-time note preferences where with a bridge in specific that we're working with, you're able to specify concise or comprehensive. As an internist, I prefer the comprehensive piece, but you can certainly make it be even more concise for you. And then the note showing up integrated right into the progress note. We saw this on the left side with the clinical note summary and then the patient summary where you have the 8th grade version in the transcript, and then you can paste that into the patient instructions so that goes under the after visit summary. All right, moving on. Many of you may have heard many of these terms, and what do these terms mean? And I would just give you a very high-level Venn diagram of AI, including tools like speech recognition, with a smaller set inside of it for machine learning, which is more specifically natural language processing and understanding the content of what you mean, like what Siri and what Alexa do at this point. Then there's deep learning, which is a subsection of that where it gets into neural networks, and these are the types of technologies that help with self-driving cars. And what we're talking about today is generative AI, the smallest bucket inside, but that's the fastest growing, which tools like Gemini, ChatGPT, Perplexity, Claude, these are trying to do better searches or trying to get at answers in much more detail than what other tools can do. So we're going to be talking more about generative AI today. This is hilarious from the internet. determining if an image is a chihuahua or a muffin is remarkably difficult. All right, so moving on to in-basket automated response tech, what we used to call at university PAM chat. And a polling question which I don't have the fancy tools for, but just for you to think about for yourself. How many online messages does a full-time primary care doc receive from patients per day? And just keep that in your head. How many do you think the correct answer is? And I'll just move on and say that at university, it's clear that CT Lin ruined healthcare, because you're welcome. Just before the pandemic, at university, we used to receive about 53,000 messages per month. And if you follow the magenta line after the pandemic, that number tripled, more than tripled, 350% increase. And leaving aside those two spikes of artifacts, we now receive 183,000 messages per month. That number has stayed steady since then. We're in fact up to about 190 to 200,000 messages per month from patients. And so it's quite a substantial volume, even though the other in-person visits and hospitalizations and video and so forth are fairly steady numbers. Patients have found a new channel to communicate with us. And so yet again, CT Lin's ruined healthcare. I'm sorry. Healthcare ruined, everything ruined. So the answer from national statistics is that the typical PCP receives 20 to 40 online messages from patients per day. This is typically pajama time, although thank you to Mark and Rob, we've at university protected one slot per half day for Thrive or Tactic time, allowing clinicians to deal with some of these messages during work hours, which allows better teamwork and going forward. So the idea from an AI standpoint is to think about, can a draft reply for doctors and nurses to use might be helpful if an AI can take that message and give you an original draft. And so this is an example. I think Dr. English, thank you for sending this along from the patient. Hey, what's mixed urogenital or skin flora? And the generated reply without any intervention from the clinician is the following. I'll give you a second to look at that. I mean, it's not bad, right? And so some of these, what you might consider nuisance questions that are about terminology, the AI can actually be very good at it. And the options here are you can start with this draft and edit it, or you can start with blank if you don't want to use it at all. And we have our clinicians being able to choose from that. We have about 50 practices using it at this point. Our prompt, we've evolved since then, but this is the beginning of the way that we drafted our prompt to ask the engine to begin every message with hello, first name, and then a preferred name, and then thank you for your message, and then the reply. And end every message with this automatically generated by. And so here's an example of something that our MAs have used to reply to the patient. And the generated reply says, I mean, it's not bad. And in this case, the MA basically said, that's an acceptable reply, send, and then go off and do the task. So the AI doesn't actually do the task. It doesn't do what it promises. Oh, I'll go ahead and refill that. You'll actually do the task separately, but at least the reply to the patient is completed. And then next example. And the AI says, and we do give the AI a list of medications in the medication list, and so it does know whether or not this is on the med list. And if it's not on the med list, it alerts the clinician to say that's not on the med list, and would you like to talk about it further? So the AI does have access to that. It does make an error in the early going before the engine was trained. Our first draft of this engine about a year ago stopped training from the internet in 2021, and at the time there was no RSV vaccine. So it would tell patients, oh, it doesn't exist. So we actually had to teach it. There is a vaccine, and please say the following. So there are tweaks that you have to make sure that it's not making an error systematically. And our team sits and reviews these responses once a week to make sure that we're keeping up with what medical literature recommends. There are wow moments. So here's one. And I'm not sure I would be this well worded. Your gratitude and satisfaction with our services are more than enough for us. That's remarkable. Right? And then we do have incidents that occur. Here's one. A thin yellowish liquid that trickled out like a pretty good bloody nose. And what does the AI say? It says, which, I mean, it's not wrong, right? If you worked in a neurosurgical practice and you just had an operation but it has no context for where you're working, whether this is a primary care practice. And so you do have to watch out. This message was transmitted by one of our nurses to the patient, and the patient immediately came in demanding an immediate visit with the doctor. And of course, this was an incident that we had to escalate and figure out, well, do we need to be careful here? Yes, we do. It will occasionally say things like this that are not clinically appropriate for the right situation. We have other wow moments. Here's one. And the answer is, that's a wow moment. This is from a rheumatologist who we show the AI the last progress note. And in the last progress note, there was the diagnosis of rheumatoid arthritis and swollen knuckles. And what a lovely, elegant message. The rheumatologist sent this with no editing to the patient, and it worked out quite well. So there are these great moments that occur as well. Here's another question for you to keep in your head. And let's just move on. So Dr. English, thank you very much. We've co-written a paper on the utility of AI-generated messages and published this in JAMA Network Open. At the time, we had something like 9 practices live on it. I think we're up to close to 50. Dr. English, are you on?
Yep, we just went up to close to 50.
Close to 50, and that's a couple of hundred clinicians. Do you remember how many we have now?
We aren't tracking by clinicians, so I don't know.
Yeah, okay. And we offer this to medical assistants, nurses, and physicians, providers. The idea is that nurses and MAs should be able to intercept the vast majority of these and reply to patients. The interesting thing that we're finding is that it's enjoyable. It's kind of fun to have people say, "Whew, can you believe it wrote that?" And of the groups, our nurses are most satisfied with the draft responses, which has something to do with how the technology is set up. I think the concern that showing messages to MAs, the MAs are tempted to give clinical advice, and instead of forwarding it on to nurses or clinicians to give that advice. So there's some tweaking that I think we still need to do in the technology. It's not quite set up exactly the way we'd like it to. And also, the usage of replies, somewhere between 10 and 15% of replies incorporate this. And it is improving, but again, it has a lot to do with prompt generation, prompting, and then also how much of the chart do we give it? Because right now we just give it the last progress note, and we need to give it more of the past chart, which would be more expensive, more compute power, in order to have better context for what to say back to the patient. So this is something that we're gradually opening up to more clinics. Moving on to summarization. And we don't have much going on here yet. We're sort of in the alpha beta testing phase. And we think maybe later this year, maybe into next year, there might be use cases. So what you do is you open up a chart. The vision is that when you open up a chart and you haven't seen the patient for 6 or 12 months, what's happened to this patient? How many notes do you have to read to get up to speed? And can this engine give you in 3 or 4 paragraphs everything that's happened to the patient? So here's a sample reply. It actually will annotate where it thinks these sentences come from. So if you're curious, when that acute myocardial infarction was, you hit the reference and it takes you to the actual progress note, hopefully to minimize hallucinations. But that's something that's still in beta over time. We think that maybe transfer of care is a great place to use a tool like this. Automated discharge summary, if you can imagine, taking away those hours that you spend writing a discharge summary, and then maybe prepping for a specialist consult and trying to see if this is appropriate to receive this person into a specialty practice, and then maybe reviewing for an annual visit, being able to summarize the last year of care. So we have some big hopes for this, but not currently live in production as yet. Moving on to the idea of transparency and whether a nutrition label might help. So here's another polling question. True or false, Colorado has a state law regulating artificial intelligence. I think we all know that there was an AI statement made by the White House that has now, I think, been retracted nationally. And the question is, does Colorado have a state law? And the answer is yes. So we are the first state in the country to do so. February 1st of next year is when this will go into effect. And there are developer responsibilities for algorithmic discrimination in informing the Attorney General. And then deployers' responsibilities, not just the developer, but the deployer. UC Health and other organizations deploying AI should take reasonable care to protect against algorithmic discrimination, implement a risk policy, review the impacts, notify consumers if the AI system is making a decision, and then allow consumers to correct personal data and appeal adverse decisions. Really hard to know exactly how we're going to do this, and these terms are vague enough that I think it'll be interesting how organizations will take this rule and try to figure out what to do with it. And then consumers, business must disclose to consumers when they're interacting with an AI system, which if you're doing background monitoring with AI, how do you do that, right? If you're looking for sepsis, for example, in the hospital, and you're monitoring 100% of patients, do you have to have patients be acknowledged to do that? Do you put that in the consent to treat? I don't think we quite know exactly what to do with wording like this, but that's something interesting to be moving towards as a North Star. So here's my idea on how this might be improved, right? So if you look at the nutrition label from the FDA, it's pretty well laid out for calorie count and cholesterol and sodium, things you need to care about. And can we try to keep it simple, stupid? Can we figure out what one thing people care about with AI and make it into something simple like this? Is there a glance and go for this? Are there smaller topics? Can we design this in small multiples in a consistent display so it's easy to sort of glance and get, what am I dealing with when I'm thinking about this particular artificial intelligence? And so here's my take on it, right? Thinking about why, how, who it applies to, who benefits, who it was developed by, and who's double-checked it. Thinking through this exercise, maybe we come up with something like this for in-basket, right? Chatbot draft reply. These are AI facts. Help clinicians reply to online messages. AI writes a draft. Result is that 15% of these drafts are used. It's used by staffs and clinician, and patients, staff, and clinicians benefit. There is a risk of inappropriate advice. There is benefit of quicker reply to the patient. This was built by Epic Wisconsin with the assistance of Microsoft OpenAI. And then something about, is this generative or predictive? Is this current use? Can you opt out? Who is it approved by? Is there a human in the loop? Is it HIPAA compliant? Is it fine-tuned locally? Is it reviewed for bias? And the answer to the last question is not yet. We're trying to figure out what to do and how to get there. Right? And if you do this as small multiples, then you look at the other projects that we're looking at, in-basket art, chart summary, ambient notes, and try to figure out, can you put AI into boxes like this, and can it be easier to understand if we try to come up with logos and icons so you can get a sense of what's happening. So just an idea. Moving on to our next topic, something I worry about for our coming years, which is automation complacency. And I think we're already starting to see this with dictation. The worst thing I've seen that my colleagues have done is put a disclaimer into the note that says, dictated using speech recognition, please recognize using context what I meant, with the implication that I couldn't be bothered to read the note myself. So, come sue me. I think it's not a great way to be documenting your notes and to actually have a paragraph in your note that says, look, I'm not very careful with my notes, so good luck. It's not a great way to go. But just to move on, just the idea that there's such a thing as automation bias. If the training data that an AI is trained on, then maybe is biased, and then maybe we replicate that bias. And then in terms of complacency, could it be that our radiologists, if we have an AI helping spot nodules, that AI will spot them for me? It's not my problem. I don't look for the nodules. They're going to spot them for me. Or it's not my fault. I use the pathway. You know, I don't have to think anymore. It's not my problem. It's someone else's problem. And are there strategies like, do you get variable support from the AI on an unpredictable schedule? Certainly, when we had an epic downtime the other day, clinicians had no support, and you have to sort of take a blank sheet of paper and write your orders yourself or fax things. Or do we have support on a schedule? You get full AI support some weeks, you have partial support other weeks, like it's looking after me if I miss something, or some weeks there's no support. Or maybe there's AI that's called adaptive AI that's now a human partner, and it can detect based on my iris dilation or my voice how stressed I am as to how much help it offers me versus letting me do my own work and developing or keeping my own skills. Don't know the answer to any of this. And one of my ideas is, could it be a Greek chorus, right? To combat human complacency, maybe it's not one AI, it's several AIs with different agendas. And maybe your job is to be captain of the ship. And here are the AI entities that I think I would like on my chorus. A main hero, trained on my data, who sounds like me on my best day. A patient advocate who insists on maximizing satisfaction. A quality maven that reminds me of all the quality standards. An F1 driver who's like, you know what, whatever the fastest way is. And then the wise sloth who's like, you know, everyone gets better with time. Just wait. They're going to be fine. Don't do anything. And then the evil genius who points out all the flaws in my thinking. And maybe I have this background cacophony of people with conflicting advice, and I have to choose the right way forward. And that would keep me on my toes. Something like that. All right, I'm going to stop here and say that there are lessons from generative AI in healthcare. Ambient notes have great promise. It's still improving. In basket art, 10 to 15% usage of the draft replies, and it's occasionally astounding and occasionally quite disappointing. You have to be careful. Chart summary is not quite ready. AI transparency is not going to be easy. There's no obvious way to make the black box transparent to patients or to clinicians. Automation complacency, I think, is something we have to watch out for. It's going to get worse before it gets better. If the AI is not thinking, and I think less because there's less cognitive friction for me because the note is done, then who's thinking? You know, and then finally, please support your friendly neighborhood informaticists, because we're at the junction of medicine and IT, and we're out there worrying about all of this all the time. Dr. Seja, Dr. English, myself, others who are in our time frame, we worry about this. And these are some books that I've been reading outside of healthcare to think about what's coming for us with the AI acceleration, and they're going to be kind of interesting. And then I have a blog that some of you read, and if you read, you'll double my readership from my mother, so that'll be great. And that's it. That's the end of my talk. And before we go to Q&A, I would love to sing you a song, unless, Dr. English, you have a comment.
I do not. No, I want to hear the song.
Steve, do we have any, well, before we go to Q&A, we will have some time. If you don't mind, I will play you a song. Do I have lyrics? I do have lyrics. So this is a song that Casey Green asked GPT, and I adapted it for what we learned. It's a little bit late for the season, but to Winter Wonderland, this is EHR Wonderland. And I'm hopeful that you can still hear my instrument while I sing for you. Doctors type, are you listening? On the screen, data's glistening. In pajamas we write, we're working tonight. Logging in an EHR Wonderland. Pop-ups flash, screens are slowing, servers crash, stress is growing. We think and we frown as our notes bog us down, struggling in an EHR Wonderland. With a bridge, our clinical conversations turn into medical H&Ps. They'll say, is it done? And we'll say, yeah, man. Just grateful for this technology. AI scribes, now they listen. Ambient notes, already written. With goals all aligned, docs and patients will find thriving in an EHR Wonderland. Thriving in an EHR Wonderland. All right, now we're ready for Q&A. Thanks, everybody.
We'll open it up if anyone wants to unmute or type their questions in the chat. Please go ahead. Oh, and we've got some applause emojis for you as well, CT,
Thanks.
in the audience. I'll start out with a question, and admittedly, this may not be a fair question, and so I'll ask you to just answer the best you can. So, background prefacing this, I'm really excited. I'm not part of a bridge, but I'm really excited about all of these developments. And for me, I think it's a way for us as clinicians to try to be more efficient in some of the work we're doing and be able to dedicate that time focusing on that patient in front of us. I also worry and see the potential that if we're being more efficient in those encounters, that maybe it's not that we get to spend more time with that patient, but we're spending less time with this individual patient and seeing more patients over the course of the day. Um, where do you think that balance is or that direction is heading?
Boy, you go right to the heart of the problem, right? So this is, we know that physicians and particularly primary care providers are extremely overburdened with the administrative work of electronic health records and with the complexity of patient care. And I'm very grateful to Mark and Rob for Tactic and Thrive Time that we're blocking now a half an hour or one session per half day that has substantially improved the ability to manage asynchronous desktop medicine work that wasn't recognized at all before. And still many organizations do not do work like this. A bridge, I think, and ambient in general is one significant opportunity to claw back some of that cognitive time to be able to have that automation reduce the burden for pajama time after hours. And so at this point, UC Health's main initiative going forward is this is a wellness initiative, and there's no requirement to increased productivity. Looking around the country, that's quite variable. There's some organizations that say you don't get this tool unless you promise to increase by X amount. From what I understand, there are some organizations that say even without the requirement of increased productivity, clinicians are saving sufficient time that a fraction of clinicians will agree to increase their visit volume. And in a fee-for-service world, even a small increase can offset the cost of the tool. I think the average is showing about 2 more patients per week is sufficient to offset the cost. But again, reiterating this, for UC Health, there's no requirement for an increased productivity at this point. So the balance is TBD. I think if you draw the dotted line out far enough, every EHR will have this built in. And the question is, how do we migrate from where we are to where we need to go? Because at a system level, for something like 4,000 clinicians, this is not inexpensive. It can be on the order of millions of dollars beyond what our license for drag and speech recognition is, for example. So it's not a done conversation, but at this stance, many organizations are taking this as a clinician reduction of pajama time effort, not as an increased productivity effort.
CT, can I ask what the cost per license is?
It's closely held to the vest, but if you work out about 2 visits per week is the offset cost for being able to make this budget neutral for most organizations.
So roughly $1,000 a month?
Significantly less than that.
Less than that, okay.
Yeah.
We do have some questions in the chat. Ingrid asks, do you think we're moving towards systems that will eventually replace us?
Well, depending on the books you read, right? I referenced several books there. Artificial general intelligence is coming for all of us, and then none of us have jobs anymore, right? You would think that clinician skill would be something that would persist many decades into the future, and the answer is we don't know. We would love for our early next steps to be that the administrative burden dramatically is reduced because the AI can handle all those rules and you can focus back on the patient. And that's where we hope we're going next. But to the point of, if you draw the dotted line out far enough, would you say Maybe the only time you get to interact with a clinician is for in-person visits and asynchronous work like online messages. You only get mini-me. And a mini-me that's trained on all of my records and messages that I've written in the past decade in the EHR, and you get to interact with the AI that is mimicking me, but you only get me when you come and see me, whether it's a telehealth visit or an in-person visit. So I could see pieces of the work dropping away because the AI helps us. Would it replace me at some point? I don't know. Yeah, this is the big question that everyone's asking.
And then John asked a similar question. So John, I am intentionally skipping you, but just want you to know that I'm acknowledging you. Christine asked, will and how would students be able to use this technology for attending years into practice, writing notes? Super time consuming, but it does really help students and residents learn and think through patient cases.
Oh, it's excellent. Yeah, the educator in us comes out. In fact, I work with a second year student in the foundations course um, and I'm asking my student to take a Microsoft Word document with no template and write me a SOAP note front to bottom. No assistance. No check boxes for what the exam is, no check boxes for review systems. I want you to get good at writing from a blank sheet of paper. And only when you've done several dozen of these or maybe more would we say that A, even do you get a template to work from, and B, do you get an AI to write your note for you? I think you're right that there are some neural pathways that we have to build as clinicians. The cognitive friction of thinking hard about how to write a note and present it clearly, if we're not careful, those skills go away because the AI is so good at writing what sounds like a great note. But are you really thinking deeply about your patient anymore? And this is a challenge that I think our educators and us must grapple with. I mean, the tools exist, but if you instantly start as a student with an AI generated note, did you ever learn to write a SOAP note? Did you ever learn to write an APSO note? I worry about that. So this is something that's not at all settled that we're going to need to figure out going forward.
And while the wounds are still somewhat fresh too, when there's epic downtime, what do we do?
Exactly.
You have to have those skills then at that point.
As I understand it, as you're walking around the hospital, the senior clinicians are no problem. Give me a blank piece of paper. And the junior clinicians are like, I have no template. Well, how do you even start? Yeah, I think these are skills that yeah, we have to be careful about.
And then there's been some discussion in the chat, and Eden's been answering some too, but I'll ask you to you as well, CT, to comment. So for the AI generated responses to messages, it looks like about 15% of the time ends up being used. 85% of the time it's not. Understanding for the reasons why for that 85% of the time, and how do we potentially improve that?
Exactly. Right now, we do have token limits for how much of the chart we can give it. And part of it is patients are asking, what does that CAT scan mean? Right. And right now, we're not giving it access to many of the test results. And so it says it's important to make an appointment to come in and see us, which is not a satisfying response. But we also don't want it over-interpreting or without having significant context of the patient's past history in the context of this result to be able to say something useful. So there's pieces of the chart that I think, tell me what the specialist said. And well, we're not giving it access to the specialist, right? So the more tokens, the more parts of the chart you require it to read, the more expensive a reply is. Right now, it's on the order of 10 cents a message, 5 to 10 cents a message per reply. But if you're only using 1 out of 10, then it's 50 cents per used reply, and you multiply that times 53,000 messages per month, or 200,000 messages per month, and it becomes quite pricey. And the number goes up if you're giving it the entire chart to read to get a better response. So prompt engineering, iterative training, trying to make the models better. I think the number's only going to go up, but it's going to take some time to get there.
I'll have this be the final question for the Q&A. It's actually really thought-provoking for me. I'd never considered this. Liz is asking, can you imagine a future in which patients use generative AI tools to draft messages to their doctors, and then AI is writing a response back to the patient, and what this does to the clinician-patient relationship?
Yeah, exactly. I love it. I think maybe, yeah, we each spin off a separate personality, and the two personalities interact and argue with each other. And out the other end, you have a nice summary. We had a long conversation about how you and I are interacting, and here's 3 lessons for you, and here's 3 lessons for me. Like, how interesting would that be? I don't know. This is a fascinating new space for us.
This has really just been a wonderful Grand Rounds. Thank you so much, CT. I certainly learned a lot. I think a lot of our audience members did too. Really exciting work we have going on. And so just thank you for presenting it and explaining it.
I appreciate it, Steve, and everyone. Take care.
Thanks, everyone.